My name is Dr. Ashok Seth, and I'm the chairman of the Fortis Escorts Heart Institute in New Delhi, India. Aortic stenosis is a blockage of a valve, the main valve in the heart, which as age goes on degenerates to become narrowed. And when it narrows up, and nearly 5 to 7% of the elderly patients beyond the age of 75 have a narrowed valve, the heart starts failing, it cannot pump blood to the rest of the body, and it becomes a very serious condition. And sometimes, as people get symptomatic with dizziness, unconsciousness, heart failure, people can die suddenly. The survival becomes just 2 years. Now, in the past, this had been only amenable to an open heart surgery, really opening up the heart and replacing the valve. But over the last 10 years, the transcatheter aortic valve, which means an angioplasty-like procedure performed non-surgically in the cath lab, Transcatheter Aortic Valve Replacement, or TAVR, has actually replaced the open heart surgery completely. And at present, if I talk to you, all the trials, be it inoperable patients, be it in high-risk, surgically high-risk patients, be it in intermediate and now even in low-risk patients, catheter-based angioplasty-like procedure which replaced the heart valves is been proven to be not just equally good, but in many cases superior even to the time-tested 50-year-old surgical aortic valve replacement procedure. So now we say that anything beyond the age of 70 should actually be considered for transcatheter aortic valve replacement. The obvious advantages in a non-open heart surgery-based procedure, angioplasty-based procedure, is that it is actually performed in the cath lab. Like an angioplasty, it's performed in a conscious patient. It practically leads to mobilization the next day and shift to the ward. And on the second day, just like an angioplasty, most of the patients are going home. And the risk factors are less than 2%, far less than surgical aortic valve replacement in these elderly patients, some of whom are 85 and 90 years old. So it is a very successful procedure. It is now accepted worldwide as the treatment of choice for most patients of aortic valve replacement, calcific aortic stenosis. And I think that now when we come to India, now in the West, it is a large number of these procedures are done. Practically 150, 200,000 procedures every year. In the West, this has now become the standard of care for most people above the age of 70. Of course, a part of the team, which is very important, is that surgeon, angioplasty or interventional cardiology expert, echo specialist, radiology specialist, anesthetist, physician, all form a part of the heart team to make this decision between surgical aortic valve replacement, valve replacement by surgery, or by this transcatheter methodology, and in most instances it is by the transcatheter valve methodology. In fact, there are many surgeons who do transcatheter aortic valve replacement, and every month 3,000 to 4,000 of these cases get done in the United States and Europe. But what is important is that India has 5 lakh at least such patients with aortic stenosis who are not being treated, who are unfortunately, and half of these, in fact 3/4 of these are not even suitable for surgical aortic valve replacement because they may have lung problem, they are elderly, they have kidney disease, etc. So in fact, when you look at that and you look at the small number of surgical aortic valve replacements being done and the large number of patients who are suffering, the landscape in India is that not enough TAVR is being performed, or not enough patients are benefiting from this advances in technology which have happened from the West. Interestingly, we'd introduced this technology and were part of the first in-man study in 2004, and yet we only got the approval of the device into this country in 2015, but we started doing these procedures in 2012 by special access to the patients. I think our patients need to benefit from these advances in technology because there are loads of people in India who are suffering and dying from this disease process and are not having access to this technology. So one of the important aspects of transcatheter aortic valve replacement is that all the devices are coming from the West, and the reason why we're not being able to benefit large volumes as we want to do is because of the big expense of the device itself. the cost is high, and therefore less and less people can afford it. And then, of course, there's issue regarding understanding, issue about knowledge, and a lot of society needs to change to believe that even an 80-year-old needs to have good quality of and longevity of life, and not just have a feeling that I'm now old, why should I continue to pay so much for to just survive? But on the other hand, I think the technology in India on the MyValve front is important, because again, it's the make in India. It is research, science, development for the benefit of getting the cost down for Indian patients, and yet providing the highest class of technology to the Indian patients. In that way, MyValve has been another advancement in showing the world what India can do in research and development. It is a balloon expandable valve, researched, developed and created in India, almost like the ones created in the West, which have been traditionally used. In fact, in a way, some of the designs of the valve created in India, the transcatheter valve created in India, were even ahead of the times of the Western valve, in terms of the fact that it was low profile, in terms of the fact that the way it was crimped, the ease of implantation, the ease of putting it in, all those were ahead of times. And that is why, according to the regulatory authorities of India, the Indian valve was again put into the trial in Indian patients in a study called MyValve 1 study, of which I was privileged to be the principal investigator. The study was on 30 patients who had severe aortic stenosis, were LD, were at high risk or intermediate risk for surgery, so therefore could not have surgery or could only have a risky surgery if needed. And in those 30 patients who were followed up for a month, up to a 12-month period, what was seen was that this valve performed exceedingly well. The mean age of these patients was 78 years. And at 1 month, at 6 months, at the 12 months, interestingly, all the valves were functioning well. There was no problem related to the device itself which was implanted. There was no leaking of the valve either. And one of the other aspects one looks at is the need for a permanent pacemaker, because the way the valve sits, a pacemaker may be needed in 10 to 15% of the patients. With this valve, no patients required a permanent pacemaker, as opposed to the studies in the West. So this preliminary study, and I must say it's preliminary because it's 30-patient study, showed that the device was safe and the device was effective up to 1 year of follow-up, as mandated by the regulatory authorities of India. This encouraging study led to its approval by the regulatory authorities of India, and the MyValve got approved in October of last year. There were another 100 patients who have subsequently been followed up and are being continued to follow up. And this is not a 1 year study, because the study goes on 2 years and 3 years for a 5-year period. But the 100 patient data also helped this valve to get the European, what we call a CE mark approval. And the data was presented in the late breaking trials and again at the EuroPCR, which is the largest meeting of the world, again received with great expectation. In fact, not just that, this Indian valve is now being used in many of the countries in Asia Pacific, and yes, even Europe has started using the MyValve. I think this is a true leap forwards for India, for a greatly advanced technology, which till now had only come from the West, from United States, to actually come up with a valve which now can actually be sold in Europe and can be used in Europe at a much lower cost than the Western valves, is a great credit to Indian science and a great contribution for Indian science to the rest of the world. I think more longer studies need to be done. We're not stopping here. We have to understand that larger studies need to be done. Longer studies need to be done. We need to have robust, longer-term data for follow-up. But at the moment, what we can say is we have what looks like a very safe and effective valve. And we are proposing that larger studies in Europe are going to be done, larger studies in South America are going to be done, and we're going to see more of this device come into the frontiers in the world in the period of time.